me okay? We're going to be using the Q&A section to answer questions. Please don't use the chat area. When you have a question, use the Q&A. Dr. Jeans, can you wave if you can hear me okay? Great, thanks. All right, good. Okay, so welcome to the Virtual Healthcare User Group. Simon Beaumont and I will be hosting the Healthcare User Group. Unfortunately, he's going to be a little bit late, so I'm going to kick off the meeting as soon as my screen. Okay, there we go. So our presenters today are Dr. John Jeans from the UK. He's going to be discussing clinical redesign using Tableau analysis. We also have Lindsay Betzendahl. She will be talking about sparking a culture of data literacy, passing the torch to clinicians. And then lastly, we have Donovan Lemlin. He will be talking about Tableau prep presentation using CMS data. Simon Beaumont is, I believe, from the UK. He's a Tableau ambassador. He does a lot of stuff on Twitter related to Sports Viz Sunday. He's also the lead for the UK Health Tug. I myself am Nicole Lohr. I work for a community hospital in Pennsylvania. I have a master's in predictive analytics, and I enjoy Tableau on everyday things I do at work. So there's a few ways to keep in touch with the Virtual Health Tug. One way is to go to the Healthcare Tableau community online. There's a website address there for you. If you haven't visited that before, there's a lot of great information. You can post questions there about Tableau and healthcare related items. You can also look at previous WebExes that were done with the Virtual Healthcare group when Jonathan Drummy was the chair of this group. And then Simon wanted to give out a shout out to the Tableau FF, which is Fan Friday, I believe. It's a community initiative that encourages people to recognize up-and-coming talented Tableau public authors. Every Friday, members of the community on Twitter promote their favorite up-and-coming authors who are on Tableau Public. So if you have a Twitter account, go look for that hashtag, Tableau FF, or the hashtag UK Health Tug. And we're going to give a shout out to a couple of his favorites. We have Daniel Caroli. He is from the UK. He has a featured Oasis in Space. I believe this is his, perhaps his Iron Viz workbook that was just recently, I think, announced as being a winner. UNICEF Data and Analytics. UNICEF has a lot of workbooks out there that are interesting to play around with. Anna Kisting, she is from the United States working for Iowa Hospital Association. She has some great vids out there as well. You might want to check those out. And then lastly, we have one of our presenters today, Lindsay. Lindsay has a lot of great stuff out there. You can really see her progress with Tableau over the last 16 months, and she's doing some fabulous stuff related to healthcare, which she will talk about a little bit later. So I want to thank you for attending. Ways that you can stay in touch is the Twitter hashtag HealthTug. You could look up Simon or I on Twitter. Those are our Twitter handles. We have the community forum page, which is listed there on the screen for you. If you are interested in presenting, we are looking for speakers. Just go ahead and contact Simon or I. You can do it through the Tableau community or our Twitter handle, or even through email, which I think is available in the links that were sent with the invitations. So feel free to reach out to us. All right, so I am going to stop my video for a minute. And we're going to introduce Dr. John Jeans. Dr. Jeans has been practicing medicine for nearly 10 years. Since 2014, he has been working part-time clinically after developing an interest in using big data analysis to improve patient care and outcomes. John started using Tableau as a main vehicle for communicating insights into data in 2015. Since then, John has been an advocate for the use of Tableau both on the inside in his base hospital and across NHS to support clinical and workforce transformations, as well as communicate the outcomes of academic research. The flexibility of Tableau has enabled clinicians to gain new insights into data that promote nuanced evidence-based discussions about improving healthcare in clinical areas varying from ED, operating rooms, to community and primary care. The insights to this have led to the creation and implementation of new models of care in workforce, as well as identifying millions of pounds of potential savings across the system. John is a keen advocate for using data to improve patient care and believes Tableau is a great vehicle for helping health systems to do their best with patients. So we welcome John, really appreciate you presenting today. He's going to be presenting clinical redesign using Tableau analysis, and I will hand it off to him. So John, can you share your screen?
So thank you very much, Nicole, for the opportunity to present here today. My name is Dr. John Jeans. I am an anaesthetist or anesthesiologist over in the States, and I have an interest in big data analysis and workforce modeling. Now, a lot of people ask me, why would an anaesthetist or anesthesiologist have an interest in big data analysis and workforce modeling, especially workforce modeling? And my standard answer to that is that both anesthetics and workforce modeling tend to put people to sleep. But my hope to this afternoon, well, or in this morning over in the US, is not to do that, but to just give you a little bit of a story about how I got involved into using Tableau and how I think the outcomes from the analysis that Tableau facilitates enable us to make a difference to our patients. I'll just start off with a little bit of background. I used to be a normal anaesthetist, if there is such a thing, but about 4 or 5 years ago, I had a serious diagnosis in my family with my dad. And when we got this diagnosis, it was a diagnosis of cancer. When I got this diagnosis, I sort of looked around at different ways that he could be treated and spoke to colleagues and came up with a management plan to try and cure his cancer. And what became clear to me is that it was very, very difficult to get the right data in the right place, to have an evidence-based conversation with people, to look at how we can give the best care for patients. And the only reason that I was able to get the best care for my dad is because I was inside the system. And I knew the doctors to ask, I knew the experts to speak to. And something about that didn't feel right to me. Ideally, what we want is a system that allows all patients to get the best possible care so that they can lead their lives to the best of their ability. And it was through that experience, it made me realize the power that data can have to influence decision-making, not just for clinical medicine on the shop floor, as the case with my dad, but also in the organization of healthcare systems. So I actually took some time out after this experience of my dad's illness from clinical medicine to learn a little bit more about how we can use data to change clinical practice and to implement new models of care and new models of workforce. And about 2 years ago, returned to medicine part-time, about 3 years ago now, part-time, and have set up a company with a couple of other like-minded doctors, data scientists. We're big advocates of using Tableau to try and drive changes in clinical care. A bit of housekeeping first. My clinical work is currently at Imperial College NHS Trust, and I use Tableau along with some of the other doctors I work with in our company 33N. I'd like to say a big thank you to various organisations, the National Health Service in the UK, specifically Health Education England and East Lancashire's Hospital Trust, because they have consented for the use of their data as a case study for this, and as well as GE Healthcare, who've been very supportive to us as a team in using this kind of data to inform clinical transformations and collaboration and their collaboration support. The reason that Tableau makes a difference. It's probably best if I start with a story about how I was introduced to Tableau. It was about 2 or 3 years ago. I was working with a good friend who is an analyst actually of the Olympic cycling team, and we were looking at this spreadsheet about different types of data, and it was about workforce transformation. And it was sort of a bit frustrating, and we were kind of going around the houses a bit. And he said to me, well, why don't we just use Tableau? And I was like, Tableau, what's this? And he took this spreadsheet, and it was not huge, it was a couple 100,000 rows and 10, 15 columns, and popped it into Tableau. And within about 7 or 8 minutes, there was a heat map drawn up. And in that heat map, there was a couple of other, very quick dashboard with a couple of other charts. And you could click on the map, and the map would filter onto these other charts, and you could start to compare things in an interactive way. And I just remember thinking, what is this amazing piece of software? You can just start to see data, look at what you can do with it. And as you can probably tell from my voice, I got very excited at that moment in time, and started to become a user of it to do more and more different things. And actually, it's a fantastic tool because it allows you to link data together from multiple different sources and use it either to present, but the way I prefer to use it is actually use it to explore. So you can explore different things within the data or different concepts in the data to give an evidence base to drive change. And the key for me is that ability to explore and test hypothesis enables us, and I say us as users of people who are involved in healthcare in any way, shape, or form, be it right from database design to delivering care on the front line. If you can empower people to improve care and to make changes with good quality data, you can really make a difference for patients. And for me, if you can, doing that is the reason why we go to work every day, and Tableau is just a fantastic tool for that. What I'm going to do is I'm going to flick over to look at how we've used Tableau to solve some relatively complex problems in an exploratory manner. And I'll start off by, and this is just one of the things that you can do, but this is a Sankey diagram, and it's a 6-stage Sankey diagram. And what the purpose of this diagram is to look at individual patient movements throughout an emergency department. And what you have here at the top is a referral source, the method of arrival. So that's self-referral, ambulance attendances, primary care, and other types of admissions into the system. You then have the first point that patients arrive, which can be in the urgent care centres, the emergency department. You then have the second movement, which can be through majors or through the urgent care centres. And then finally, you end up with multiple moves within departments, or admission or discharge, and then your final outcome over 6 stages, which is either admission to the wards or discharges. Now, when I look at this Sankey diagram, what I'm seeing is not just a bunch of lines, but I'm seeing the story of the department. I'm seeing how patients move through. And it's quite evident that there's some big patient pathways. These Sankey shows, you have some patients that are self-referred, go into the urgent care centre, and then are immediately discharged or are discharged relatively quickly with these big yellow lines. The big red line is again showing those that self-refer into an urgent care centre, which for the guys in the States is like I guess it's kind of a minor injuries unit, so it's not the same as a all singing, all dancing, big trauma A&E. It's a slightly more limited environment where you can't sort out major fractures or have a big resuscitation room, deal with major trauma. But it's like a primary care setting, but it's enhanced a fair bit, and you can manage quite a few patients in there. So in this particular environment, you've got big flows of patients into the care centre, and then unsurprisingly they end up being discharged because most patients, if you go to an urgent care centre, aren't normally sick enough to need admission. Now, where it gets interesting for me is the ambulance pathways, because the ambulance pathways admit into the A&E department, and then what you're seeing here is lots of little scattered lines, and these scattered lines are showing all sorts of different types of patients. You can see man versus someone who's been hit by a car, someone who has had a horrible heart attack, a little old lady who's fallen over but who can't quite get home easily, someone who's got a nasty fractured ankle. And all of these different pathways are showing us all sorts of different of fragmentation and variability. And as we know, fragmentation and variability are the enemies of trying to deliver a consistent, cohesive service. And the outcome of this fragmentation and variability is that you have some patients, they come in, some are scattering till you get discharged, but most of them have multiple movements within the department before either being admitted to the wards or subsequently discharged. Now, one thing we have over here in the UK is we have a performance target. And the performance target in our National Health Service is that all patients who arrive and arrive to an A&E department or an urgent care centre are seen by an appropriate healthcare professional and discharged or admitted within 4 hours. Now, the issues that this particular department are going to have in terms of meeting that target are most likely, from looking at this visualization, going to occur from ambulances going into the emergency department and then into majors and then either admitted to the wards or discharged. And unsurprisingly, when we apply a filter on to look at the data in more detail, and we filter down to look at just those patients that breached the 4-hour target, we will see the emerging pattern. Now, it's important to note, and is that while I absolutely love Tableau and I love Sankey charts, I am not the person to build you a Sankey chart. I know kind of what I want to see from one, but to actually build one is incredibly complicated. As you know, the guys who are really, really good at Tableau will understand. You have to have all your plot data, which is joined, and duplicate all your rows by 100. Have a whole bunch of nested table calcs. For me to say that I can use nested table calcs appropriately, I can't, but it's I can appreciate how these are built. And obviously I can use basic table calculations without too much trouble. They're just fun to play around with at 3 a.m., which probably shows I need to get a bit of a life. But anyway, if we look here, what we can see is that the thin fragmented lines, the variable lines that we were looking at before, are now the big fat pathways. So the pathways that that illustrate breaches are patients that arrive via ambulance, they come to the emergency department. When they go to the emergency department, they have multiple moves within the department before either being admitted or subsequently being discharged. So already, with what is a relatively simple analysis, we now know where to start looking to look for ways that we can improve patient care, and we know what types of patients we need to focus on. It's ambulance arrivals that come to the A&E department and have multiple moves. But medicine isn't, unfortunately, just focusing on those patients won't give us the full story, because medicine, as we all know, is never quite as simple as that. What we then need to do is start to look at other factors that come into place. So we can look at the next thing to look at is the occupancy of the department. Now, again, this is another visualization. This is using running sums that are done with table calculations over stacked data. And what we will be able to see here, and I'll just expand this out so we can look at a slightly wider date range. So we're going to look over a 2-week period in August. So what we can see here in this 2-week period of August is that the grey line is the total number of people in the department. The red line is the number of people that breach that 4-hour target that I was talking about earlier. And the blue line is the number of people that don't breach. Now, as we can see here, in the urgent care environment, broadly, as long as the numbers tend to stay under 20, maybe 25, we're okay. The 4-hour target tends to be met. But when we go over that 4-hour target, over 30 odd people, we tend to breach that 4-hour target. In the majors department, which is where we were talking about earlier, you can see that performance is maintained if we are under that, if we're under the 20 mark. As soon as we go over the 20 mark, we can see that the red line creeps up and most of the patients that are in the department then end up breaching. Now, it's all well and good looking at this in the summer. It's important this out in the winter because, as we know, that seasonal variability is dramatically impacts upon demand. So what we need to be quite clear about is that the trend that we're picking out, it could potentially hold. And when we move over to look at the winter, again, the similar trend for urgent care. If you get to above 30 patients, you tend to get these rises in the red line and worsening performance. But broadly, if it stays under 25 or 30 patients, things tend to be okay. In majors, the trend holds. if you have over 20 patients in the department, performance really, really struggles. And it's only when you get some recovery in performance, either blue line coming up, when you get down to under 20 people in the department. Fine. What we've been able to establish is we know which pathways to look at, and we know how occupancy can potentially impact upon these pathways. But the next thing to then say is this relationship true? We've had an observational relationship, but what we want to do is we want to try and make sure that what we've observed over a couple of different time periods in the data actually holds out. And the way that we can look at that is we can look at the occupancy of the department with another view. And again, we're looking at the occupancy on the x-axis here and the percentage of patients that meet the 4-hour target on the y-axis here. Now, as you can see, there's a linear relationship, and it's quite a stark linear relationship between the occupancy of the department, but also the percentage of patients that breach. As the occupancy increases, your percentage chance of breaching, if you arrive when the occupancy is 19, goes from 39% at the occupancy of 19 up to 56% when your occupancy is 25. This suggests that in order to move things and improve things for this patient cohort, what we need to do is we need to reduce the occupancy of the A&E department. There's a range of different ways that you can do that, and I'll go on to show the modeling that you can do for that in a second. However, when we look at the urgent care environment, we can see that the relationship between occupancy and performance is not so linear. This is not so linear. It seems to be more of a flat line. And what we're suggesting, the only time it tends to be related is when you get to the extremes of occupancy, i.e. 31, 32 patients over in Burnley and 40 patients over in Blackburn. What this suggests is that the issue that we need to solve here is a process issue. And solving process issues is different to solving occupancy issues. Occupancy means we have to shift activity away. And that's going to be involving a new model of care and potentially a new model of workforce. Process improvement will potentially, won't necessarily require a new model of care, but it will require the workforce to work in a different way. And that's by doing things such as applying the theory of constraints. So subordinating all of our processes to our most constrained, our most constrained worker or most constrained action within the department. This could be the access to a senior decision maker, or it could be the access to a certain type of investigation. And you can drill down into the data to look at that in a bit more detail. For the purposes of this user group, I probably won't have time to show you all the row-by-row analysis that we have down here that will allow us to do that. But as you probably can tell, I'm more than happy to talk about this at any moment in time because this stuff is great. If we want to look at reducing occupancy, Tableau is very helpful in visualizing how we can do this because there is this ability to use a whole range of nested table calcs to get a different view of modeling what-if scenarios. Now, I'll give you, I'll look at this view so that we can get an idea of how we can improve things. We're looking at majors here. We can see that as occupancy improves, what you've got is more reds, i.e. as occupancy increases, what we have here is more red patients, i.e. those that breach the 4-hour target. And again, more blue patients over here on the left when occupancy is less, i.e. those that don't breach the 4-hour targets. If we want to make a suggestion about how we can change things, what we can do is we can say, okay, fine. If we were to go back to the Sankey, and I won't go back to the Sankey now just yet, the Sankey shows us the patients that are of the highest proportion, highest likelihood of breaching. And actually, we can also look at it in the other view of patients that breach in our single row view. So these are just different dashboards to look at different patient outcomes. And I will show you once this loads up. And these are nice. So as you can probably tell, I've had to cache the other views because the table calcs generate quite a lot of, but calculating all those things on the fly can be a bit of a challenge. But if we simply look at those patients that are admitted to the wards and those that breach, and I've got an age filter on here, so I'm just going to take this off now. What we'll see is that, let's just take the age filter off now. What we will see is that those the acute medical unit is the destination for one of the highest proportion of patients that breach. So all of this analysis tells us where we need to focus our work, and that is going to be on the cohort of patients, of general medical patients that are non-specifically unwell. Now, the way that we can do that are legion, and I won't go into the clinical detail of too much about how you do that now, because this is probably not the right forum. But what we can say is, if we come up with a clinical model that reduces our length of stay for this particular patient cohort by 80%, what Tableau will then do is look at the reduction, will give us an output that will show us the average length of stay reduction for this cohort, and then look at the overall impact that it's going to have on breach on the performance stats. We can then say, okay, well, we've got one idea for acute medical ward A. We can then pop in acute medical ward B. We could put in a whole bunch of other medical wards or surgical wards or anything that we wanted to. And we could then come up with a layered model that allows us to see what the impacts of our suggested changes are. And these outcomes are fantastically valuable, because what it allows you to do is have an informed conversation around the evidence base to look at how you can identify cohorts of patients that you can say, yes, this cohort, there's an issue with what's happening to you. Here's the evidence base about why this is happening, and here's a new model of care about what to improve your experience. And this is what the outcome is going to be, not just for you as your cohort, but also for you as an organization. And as you can see here, a new model of care, which in this particular case will involve an ambulatory an emergency care unit that can reduce the length of stay in the department by several hours, is going to improve the overall performance by 12.9%. This, for me, as a way of working, this exploratory analysis that allows me to interrogate things in multiple different ways, to test a hypothesis, and to look at what modeling, what if scenarios, it's a fantastic, it's just a fantastic piece of software that enables this kind of conversation. And what's so useful, I find, is that if you bring other clinicians around the table and you explore the data together, you can then come up as a team with the best possible method for improving care and making things better for the patient, and also for the organization, for the working environment. I'm aware that I'm coming close to time, and I've just shown one particular use case of a suite of dashboards. As you can tell, there's a lot more that you can get out of this A&E analysis. But I thought I'd swipe over to look at some other bits and bobs that we've been playing with in terms of prescribing data, just to show the outcome. Now, in the UK, the NHS releases, as part of an open data policy, every month, all the different drug spends in primary care across the country. And what we've been doing, and this is just data to play with, I wouldn't make any sort of gross strategic decisions based off of this data at present. But what it shows is that for a particular region, in a particular region, there's all these different GP practices. And each of these GP practices, I've clicked on something, so it's now going to have a little bit of a loading, I think. Let me go back, sorry. We're looking at the Greater Manchester area of England. We're looking at every single prescription over the last 12 months. And what we're looking at is the quantity of things that are prescribed. And what Tableau allows you to do is say, okay, fine, we want to look at the number of different prescriptions that are given out. Here it is, here's the main offender, paracetamol. This is the volume of cash that's spent on paracetamol, and this is the volume that's spent on cocodamol. And then we've got other tablets down here for metformin, omeprazole, etc. And what you can do is you can interrogate the data. So you can say, okay, well, this is the quantity that's prescribed for the whole region. If I want to look at a particular area, and I'm not just picking them at random, because just to show you, so we can look at the area of Tameside, which is one region, and we can go down and say, if we look just at Tameside, here are the doctors that are prescribing certain volumes of medication. and these guys are prescribing the most, these guys are prescribing least. Now, actually, we can look and weight it per 1,000 patients, and we're building some functionality here to weight it by age, etc. So it's important to not look at this data in isolation and say, oh, well, these guys down here, they're clearly prescribing most. We haven't weighted the data, and we haven't we haven't weighted the data to allow for that. So I guess the point I'm trying to make is that with Tableau, it doesn't really matter whether you're looking at A&E data and patient flow through A&E and clinical transformation options, or you're looking at prescribing data for the entire country. The ability to take all of this data, collate it together into one space, and allow people to explore, test hypotheses, come up with assumptions, have evidence-based discussion. What this enables us to do is to come up with the best model of care for our patients and to fundamentally ensure that people have a better experience than my father did 5 years ago with his diagnosis. I realize I've got to about 25 minutes here, and I don't want to overrun for everyone, so I will sign off at this moment in time. But I just want to say thank you to Nicole and Simon for giving me the opportunity to present, and I look forward to hearing any questions, I think, at the end. Thanks very much.
Thank you, Dr. Jeans. Simon was able to join us. Are you there, Simon?
I am indeed. Thanks, Nicole, and sorry everyone for being a little bit late. I think it's fair to say I absolutely adore listening to Dr. Jeans. Every time I hear him, he presents something new. But the thing that comes across to me is it's less about the technical and more about actually having that person that interprets the data and adding value. And the way he describes healthcare data in the UK makes it so engaging and easy for people to understand what to do with it. So it's an absolute pleasure to have heard him, and thank you ever so much for joining us.
Thanks for having me, Simon, and Nicole. It's been an absolute pleasure.
Thank you. Okay, I'm going to share my screen. And our next presenter is Lindsay Betzendahl. Lindsay is a 15-year veteran of the healthcare industry and previously worked as a clinical therapist before joining Beacon Health Options, a leader in behavioral health management. Lindsay discovered Tableau over 4 years ago after constant frustration with static reports and ineffective chart types that she reviewed with hospital providers. She later launched a quest to transform how Beacon utilized visual analytics and interacted with data. Lindsay is the Director of Analytics and Innovation. She leads her company in the Tableau desktop operation and server administration while supporting a team of analysts in their dashboard development and design. In addition, Lindsay is very active on the Tableau community and regularly participates in Makeover Monday. She recently launched Project Health Viz, which she will go over in a little bit, earlier this year, and it will her initiative is to increase healthcare visualization and provide data sets for members of the healthcare Tableau community. She's a busy wife and mom of 2 boys, and in her spare time enjoys being outside hiking, snowboarding, and enjoys craft beers. So we welcome Lindsay.
Hello, thank you. Can you hear me okay?
Yes.
Excellent. All right, I'm going to try to do this screen thing again.
Yeah, I have a feeling my screen was not being shared. Sorry.
Okay. All right, I got to swap this. How's that?
You need to display your settings again. There you go.
Good?
That looks great.
Excellent. Okay, thank you so much. Thanks for that warm welcome, Nicole. And good morning, good afternoon, good evening, depending on where you are in the world. It is afternoon in rainy Connecticut, but that's okay. I'm really excited to speak about sparking data literacy in your healthcare organization. So let's get this started. Let's see. There we go. Okay, great. All right, so this is an overview about what I'm going to speak about. I'm going to talk a little bit about where I work at Beacon Health Options, a little about my personal background and how that's helpful in this journey. Then we'll talk about what data literacy is and what it means, and how we have used Tableau to help us increase data literacy here, what steps we've taken to engage with our clinicians, and how we really focus our dashboard design and the iterative process ultimately to help increase data literacy. So who we are at Beacon. So we're a clinical mental health and substance use disorder management company. So nationally, we're headquartered in Boston, Massachusetts, and we have locations across the nation. We provide behavioral health solutions for health plans, employee organizations, and many government types. And we employ almost 5,000 employees and serve more than 50 million people, last I checked the numbers. So in Connecticut, we're a local contract, and we're a partnership between Beacon, and we're identified as the Administrative Service Organization, and 3 state agencies: our local Department of Social Services, Department of Children and Families, and Department of Mental Health and Addiction Services. And we manage the Medicaid behavioral health services in Connecticut. We have about 170 employees, clinicians and peers, network managers, customer service, PR, all of our clinician, quality analysts, etc. And we provide clinical services, but also a lot of data analysis and network solutions to help improve access to and the quality of care for the members in Connecticut. So a little bit about me. So my background, I'm actually a licensed marriage and family therapist. And prior to joining Beacon 8 years ago, I was practicing with children and families. And then I also had a role as the regional network manager at Beacon, which was really the launching point for my data career. It was in that role that I took data and graphs out to providers and realized the significant power of the visual aspect of data and how we could tell stories and really impact decisions. But much of my personal ability to interpret and respond to data is based on what I believe 3 core things, which I'm going to go over a little bit in this presentation. First is my clinical background and experience, my love for and knowledge of data and math, and an eye for design and storytelling, which in part is probably due to my psychology and English background, but my mom was also an artist, so I think I have some of it in my genes, or I like to think so. But I think all these pieces have really helped, and I want to speak about how those 3 aspects, how you can increase that in your organization and hopefully help drive data literacy. So what is data literacy? So data literacy is the ability to consume for knowledge, produce coherently, and think critically about data. Specifically, it's being able to collect and use your data in meaningful ways, to understand it, to understand the methodology behind it, and for me, most importantly, to be able to argue through and argue about your data, to ask questions, to be able to provide that context and story to your data. And without data literacy, literally, we end up in real challenging relationships with data. We either don't collect it, we ignore it, we look at it but don't apply it perhaps, or we apply it incorrectly, or we extract the wrong meaning from it. So data literacy can help us accurately understand and tell stories about our data. So as I've kind of alluded to, there's these 3 main aspects that together promote data literacy. You'll see in this Venn diagram of sorts, the top is analysis, then we have design, and narrative. And to some degree, these are like 3 legs of a stool, a 3-legged stool. It's certainly possible to have 1 or 2 of these elements, but really the stool isn't going to be complete without all 3. And so I believe data literacy, you have to have all 3 of these aspects. And in an organization, when you develop ways to engage your analysts or your Tableau developers with your clinicians or your end users, you're going to promote data literacy. So before Tableau, this is how Beacon, or we try to build this stool. So before Tableau, as many organizations and companies that I know have shared at Tableau conference and whatnot, speak to a similar story. So we had 1 leg of our stool really well built. We had excellent access to our data and our SQL developers. We had really strong understanding and ability to create tabular reports for end users. We're unique in Connecticut, where we have access to all of our Medicaid claims, we have our eligibility information, we have a lot of population data and statistics. But one of the challenges was, that you'll see in this data chain, is that from a data literacy standpoint, we went from our knowledge management and reporting department, who does all our SQL server development, all of our coding. They would produce things in our Oracle server. They go through Crystal reports. They may end up in a PDF or an Excel file. Our seasoned analysts would take that information and often remanipulate it in SAS to get some statistical analyses or some other aggregate outputs. And then we'd look at it in Excel and perhaps put graphs together in Excel. So it was a long means to an end, and often our end users, our clinicians, kind of got stuck with this tabular format that was often challenging to see the story within the data. And so here's an example of what many of you probably see or have seen, is a bunch of reports and tables that were numbers. And people got very familiar with using them, and they would find their number that they needed, but really we lost this narrative piece. And to be quite honest, I heard a lot of folks, clinicians, say they hated data, and part of it was they didn't know where to start. They didn't know the methodology. They didn't know how to ask questions. We were fortunate enough, in your top right corner, we did have an early interactive dashboard back pre-2014 when we got Tableau, but it was hard to manipulate and change. And so as our system evolved and our providers evolved in what questions they had, and our clinicians had new questions, we didn't have the ability to change this dashboard. So Tableau really helped us see our data through visual stories and modify our storytelling. So what we did. So on the front end, from our visualization standpoint, we really started with improving best practices and chart design. So we had some trainings. We did early on an initial training called Are You Smarter Than a Graph? And that was literally for anybody in our service center to learn about what chart types were appropriate for what data, what questions to ask, things, your typical best practices like bar charts you should start at 0, those kinds of things. We wanted to make sure people had a framework for asking questions or challenging data. We developed a style guide and an end user report assessment process, which I'll show next. And we created new dashboards off of our existing production reports. So we wanted to start with the things that we knew people were using. It's easy to start with a new report and transform it into a dashboard, but we wanted to go back and say, what were people using every day? Let's take that old report, let's put it into Tableau, and let's get folks using it so they can tell their stories. And then we started directing our users to the Tableau server instead of where these local PDF and Excels were located. On the back end, and this is really important, is our analyst staff, our Tableau developers, started working really closely, or had been working closely, but started working more closely with our reporting staff, our SQL developers, to really optimize reports for Tableau. So some of the old reports we had, our old tables, were not in a Tableau-friendly format, as we often say. And so we worked very closely with them to start bringing them into the fold of Tableau and how we could use this together. So we also linked directly to our Oracle server, and that cut down on our Crystal report productions. And we, by doing all of this, improved our turnaround time for ad hoc requests and reduced the need for new reports. We were able to leverage Tableau to slightly modify a question and get a new output or a new dashboard very quickly. So the audience assessment. So this is something that we work with our Tableau developers, our analysts, on how to analyze the report requester and what their needs are as they develop a dashboard. So one of the things we did is we added a collaborative meeting to all report or dashboard requests. And this meeting includes the original report requester, a methodologist, the reporting resource, and the Tableau developer. And it's here that we determine who is the audience, what do they understand about the data, what questions do they tend to have, what situations are they needing to present or explore this data? Are they going out into the public? Are they going to be sharing this dashboard to people who are not internal to Beacon? And so this was our first step towards developing effective dashboards. The second piece was the iterative process. So iterative design is a highly effective process for making incremental changes based on an initial prototype and user feedback. And I'm sure many of you are familiar with going back and redesigning dashboards after they've either been in production for a bit or after you're talking to the report requester. And so after we've had this initial meeting to understand the end user's unique needs, we research the data, we develop methodology if it's not already been developed. And then when we develop this dashboard, we go through a number of prototypes, and we use our development server. So we have 2 Tableau servers, a development and a production. And we use a development server as a place to actually share these draft dashboards, both among the analyst team so they can share kind of what they're all working on, but also with our clinical staff. So we'll post things up there during this phase and all throughout it to say, you know what, first draft's up, look at it, interact with it, tell us if it meets your needs. Is there something else you really wish you had? And they can report back and say, you know, we really need this filter, or this chart type's not working for me, or whatever it may be. And then we can keep going through and developing this dashboard alongside them until they give us final sign off and we can produce it to production. So the increasing data literacy. So I've kind of structured this where we've had, as I mentioned, our SQL programmers were this top analytic part. And they had always been doing a very good job of getting our data into clear, cleaned up information for us. And so our Tableau analysts, I would say, is down on our design aspect. And so where we merge these two pieces is we have as I mentioned, our Tableau analysts work with our SQL developers. And we also have some of our analysts who are able to write SQL in Tableau. So we're kind of blending these two aspects and getting to this clarity part, this dark purple area, where we're understanding more about the back-end tables and all these raw numbers that we're getting, and we're able to make our dashboards more efficient. Then between our Tableau analysts and our clinicians, so our clinicians are the ones that understand the story. They're the ones living this. They're working with members. They're working with providers. They know why something may have happened. You know, when we see numbers change, they say, well, that's because this provider shut their doors, and so that's why the numbers went down. You know, so they have that information that's really important.
Hey, Lindsay, really quick. Sorry to interrupt you.
Yeah.
It looks like you have something shared in the middle of your screen that's grayed out that isn't that PowerPoint. I don't know if it's like a notification or...
I don't see anything on my screen.
Maybe if you try unsharing and then resharing really quickly.
Sure. I mean, I could just do my desktop. Try it again.
Yeah, it's probably just like a notification that was hiding out somewhere.
Oh, weird. Okay, let's see. Okay. Can you see my screen now?
Yep, looks good. So if you just want to go ahead and, there we go. Perfect. Thank you.
Okay now? Okay, no problem. Thanks for letting me know.
Yep.
Very strange. Okay. So where we merge kind of our clinicians and our narration and our design are with, we actually hired some analysts who used to be clinicians, obviously myself included, as I mentioned, but now not everyone can always do this, but we've really been lucky at being able to find people who've had both healthcare and public health background that can be our Tableau analysts and our developers. Having that knowledge is really helpful. But when you don't have that, we want to make sure the clinicians and the Tableau analysts are well connected. And so again, these collaborative meetings that we have been helpful in helping us tell the story in the dashboards. And then lastly, with the SQL programmers and the clinicians. So this sometimes is the biggest gap, but we really have tried to include the clinicians into the information about methodology and how we develop reports or how we're developing the coding behind the dashboards. We want them in on these conversations because they have that knowledge about what's been going on and perhaps what methodology is going to make sense or not. And so I think additionally, a key element to all of this working seamlessly is also a strong commitment by your company's leaders and organization to truly embrace a culture of data literacy. Here at Beacon, I'm fortunate enough to have fabulous leaders who continue to support our advancements in data visualization and data storytelling, but you really have to have that framework to help make sure all these pieces are going to be well connected. So one of our first projects, you saw this image earlier, was an interactive dashboard that we had many years ago. And my point in showing this is that about the iterative process and this collaboration. This was a dashboard that was originally for our network managers who go out into the community and meet with our hospital providers and talk to them about their performance metrics, how well they're doing on like this day, readmission, that sort of thing. Because our network managers are out in the community, they're out there and they get asked a lot of questions about the data. So these dashboards look crazy. They're crazy packed with information. They have a ton of filters. Maybe some people say this is way too much, but This was a collaborative effort over the years with them, and this is one of our most used dashboards. They needed to have a highly exploratory dashboard that would allow them to answer practically any question that was asked on the fly by a provider. They're doing this live with our providers. They had to tackle all these metrics, multiple options, drill downs, etc. Without having those in-depth conversations and iterations over and over again with this team, we wouldn't have been able to develop this dashboard in such detail. We had to have that constant communication about what do you need, what questions do you get, so we could make sure that they could answer them. Another example is this is one of our performance targets, and the big story here is there's a number in the bottom right corner, 10.79. People would often go and just look at that number. Are we meeting the target or not? There's a lot of other information in here, but it's very hard to gain any trends by looking at months and quarters and all this data. So again, with talking to our clinicians, these are the folks who are our clinical staff was looking at this and needed to know, are we meeting a metric and what's driving it? We built a dashboard that was going to not only give them the answer, this 10.79 kind of in the middle of the screen here, but also if you had more time, you could start looking at different pieces to this data and were we meeting all these measures and who was contributing to us not meeting it, for example. So lastly, just encouraging data literacy and a little more about dashboard design and a couple of things that we've done to help improve our clinicians' ability to understand and challenge data. We've also started working on developing methodology pages on many of our dashboards. So one of the things I said initially about data literacy is being able to understand where the data comes from and the methodology behind it. Now, maybe there's plenty of people who do not end up in those collaborative methodology meetings. We want to make sure they have access to it. Our dashboards, many of them have a methodology page at the beginning that gives some summary information. These are two of our HEDIS measure ones that give the HEDIS specs for the year. But this way, if they want the information, they have it right in that dashboard. They don't have to go searching for someone to say, how is this calculated? And hopefully they can answer 99% of their questions here. Another thing we've done is some color consistency. So this goes with the prior slide about our HEDIS measures, but within a dashboard, we have a number of different measures, and each one is identified a color so that you can start to remember, blue is the follow-up after hospitalization, and these dashboards are all designed identically, but then there are different colors, so you're onto a different measure. So we've done a couple things just to help our end user get familiar with dashboards and metrics and what they're seeing. Next is access to information. So again, one of the pieces of data literacy is about being able to challenge the data, to challenge what you're seeing, to ask questions. So we've added a hover for help, as we call it, and one of our analysts kind of came up with this idea, and we literally ran with it. And so it's just a little button, but it's going to tell you who developed the dashboard, who initially even requested it, who you need to go through if you would like to update it, when the report ran, some of the general things I'm sure many people have in their dashboards, how often it refreshes. But one of the key things is you literally can just click on this and it'll shoot an email to the developer and basically the owner of the dashboard so that people know who to ask questions to. This is really helpful for our clinicians who are using these day in and day out. They can pop questions, say, this data doesn't look right to me, or I have questions about why this measure looks like this, or I don't remember the methodology. It's not quite, maybe there's another piece of information that they need. This is how we elicit a culture where asking questions is not only allowed, but it's really desired. We want people to challenge the data. We want people to feel comfortable enough that they can. And one of the basic pieces is knowing who to ask. And so we try to build that right in. And the last piece, or the second to last piece, is narration. So increasing the ability that your end user can tell this story. Sometimes people are very good at being able to read through all this information and glean the story from it. Other times it's helpful to put a little context. And this is an example of where we've just added a little bit of language, simple language that just sums up kind of where we're at with this dashboard, so that if someone is maybe not quite at, working on their data literacy, they can get a little summary, and they can then use that to interpret the dashboard. And lastly is about crafting stories. So storytelling is the other piece of data literacy. We've tried to, in many of our dashboards, think through how we can start at a high level of all of this data. We have tons of population utilization data that can be overwhelming. When we start high level, we tell a story. We start with, in this case, context of number of members who are overdosing in the emergency department. These are pretty serious metrics, and we want to start big. And to tell these stories, we move through, so we deliberately move through from this high level to here's where they are, where are they located, where are the cities, so now we're getting a little lower level of detail. We move into demographics and who these people are. And then after we've done all that, which I'm not going to show here, we move into perhaps the member level detail so that we can intervene and use our clinicians to then outreach to these members. And we have a lot of initiative at Beacon where we're driving change through this data and then developing programs and processes to help. So just in summary, a couple other things that we've done to help increase data literacy. As I mentioned, these are some best practices in general for dashboard design, but we've really done these things for our clinicians, for our entire engagement center. So colors and branding, clear title, had to blur out who it was, but having the methodology front and center so it's easily accessible. We've done things like put summaries in the titles when it's applicable. Just to give a little summary recap so that perhaps you don't have to go through all the detail if you don't have time. And again, kind of wherever we can, we put some contact information. If you have questions, come on, we want you to ask. We want people to be engaged with this data. And design is a process of making complex things understandable. And that's really at the basis of all of this. So just remember, it takes one idea to start a movement. And really, when we combine data with meaning and intention, we get better, smarter, faster, and more reliably predictive decision making. And so when we do all this with clarity and conscientiousness and empathy for our audience, we really get more attention and more engagement and less frustration from them. So when I used to hear people say, I hate data, now data is fun and interesting. Many of the people I work with are so engaged in this data and ask questions. And so I think all of this has really helped us in our design and visualization process and our engagement with our clinicians. So that's it. So thank you so much. Here's some other places you can find me. I think as Simon and Nicole mentioned, you can find me on Twitter and Instagram. And there's my email address here and my website that does have information on Project HealthViz, which I hope to continue going through for the year and leading up to TC18. So thank you so much.
Thank you, Lindsay. That was great. There's a couple of Q&As that maybe you can answer when the next presenter goes on. So I will share my screen, and this time I will definitely make sure it's sharing.
Thank you so much.
Okay, share screen. Share. All right.
We can see it, Nicole, so you're doing all right.
Great. Let's get down to the end here. What is this? Okay, I was a little too fast. Try again here. Okay, next we have Donovan Lemlin. Donovan is the Vice President of Healthcare Services in McCormick, LLC. He has over a decade of experience in reporting and analytics surrounding healthcare data and systems from both a clinical and payer perspective. His experience includes everything from identifying practice variation across providers within a department to coordinating process improvement programs to increase Medicare star ratings for health plans. So we welcome Donovan. Thank you.
Thank you. Can you hear me okay?
We can. You can take control and share
All
your
right. And here we go. You can see my screen now?
Yes, I can. Thank you.
All right, so let's go ahead and dive in. So as mentioned, my name's Donovan Lemlin, and I'm going to talk to you about Tableau prep and working with non-standard data. First, I'm going to go over who we are, why this transformation is needed, the old way that we did it, what's new with Tableau Prep, and then I'll dive into the details so you can actually see what this transformation looks like in depth. Who we are, McCormick BI LLC. We're a company located in the heart of the United States here in Wisconsin. You can see our contact information here. I'm not going to bore you with those details. That will be included in the presentation. And then we'll just dive into why we need the data. So we have a STARS analysis tool pack, and that tool pack demonstrates Medicare plan data based on CMS STAR ratings year over year. We have the results from the STAR ratings. We compare that up against enrollment for the same time frames. We do manipulate the data to give a single screen performance, which is highlighted here in my presentation. We do competitor analyses, enabling people to see how they're performing against their competitors. We look at performance on a plan-by-plan basis year over year relative to the cut point changes that CMS publishes, and then also year-over-year performance analysis with single plan or competitive relative change. The old way that we used to bring these data in was we used spreadsheets with formulas and Visual Basic transformation to align the data to meet our needs. That whole process took about 10 hours, and there was plenty of room for errors and needed rework because there were manual components. It was painful. At the end of the process, I felt a lot like this. Moving forward to Tableau Prep, all we have to do now is add a data source, make some additional manipulations in the process, drag in the connections where needed, and export the output. It's no problem. It's a much easier world. So at this point, we're going to jump into Tableau Prep, but before I go there, I'm going to show you what the data that we're transforming looks like in its raw format. We get this information from CMS, and these are the cut points for the Medicare Part C measures, which include a lot of HEDIS measures. They include some operational measures and that sort of thing for the health plan. They also include the consumer surveys surrounding the healthcare providers that they partner with. So looking at the data are the string values for the breast cancer screening goes from less than 56% is 1 star, between 56% inclusive and less than 70% is 2 stars, 70% to less than 78% is 3 stars, and so on. Now, that would be fine if all the measures are the same. I'm going to scroll over to the right here. And you can see that this measure doesn't have percentages. It's got floating decimal definition. And it goes from a higher score is 1 star. So this measure is lower is better. And anything less than or equal to 14 or 0.14 is 5 stars. And then right over here, I have a measure that's completely different from either of those. And bringing all this information in was a real pain in the neck. Complicated formulas in Excel, and like I said, opportunity for error and potential rework. Using Tableau Prep takes a lot of that concern away. So went from having to deal with those opportunities to get it wrong to using Tableau Prep, which we will dive into right now. And when I was told about Tableau Prep, I was excited to use it, and then once I used it, I was even more excited about it. The product really delivers in spades. So this is what my data flow looks like, and you can see here I have data for 2016, 2017, and 2015. Tableau Prep did select the order for me. Now I'm going to go ahead and add the 2018 data, which is just as simple as clicking here. Get the data flows to come through. And then we're looking at the Part C cut point, so I'll just drag and drop that here. And so we're actually going into the trenches here. So you're going to see firsthand out just how easy this is and how long it takes. So I'm going to just rename this as 2018 and double click to get in there. The data, as you'll recall, is, well, we can just dive in here. You can see the data is set up. So there are lots of rows of just simple information. I'm going to pivot that data so that we can get the data aligned the way that we want to work with it. And in order to do that, I click each one of the measures, or I start with first measure, scroll down, shift click on the last measure and drag that over into the pivot values here. And now you can see that I've got the measure name along with the values. These are all the date ranges, and F1 is the star level, and you can see these are all nulls. If I were to select 1 star, and this is one of the nice things I love about this tool is you can click a component of the data and it will take you to it will filter for the information you want to look at. So now I can see the less than 56% that we looked at for the breast cancer screening in the raw data. All right, so now I just click in the white space back here. I've got my pivot defined. I'm going to do the same function here just to get the data a little bit better lined up with where we're trying to go. So add a step. And if we went into this one real quickly, you can see that I renamed some fields. I filter to take out the null values from the star values, and then I add the year. So click on the white space again here, go in here and repeat that same step. So renaming this, I'll call these measures, and I'm misspelling it on purpose. And then this one I will call the raw scores. And again, I'm just double clicking on these field names, and this one I will call the star level. And you can see down here, it renames those fields just as I did up here. Now, if I right click on this and select exclude, it automatically filters those nulls out. And so now you can see I have the clean cut point data here. And then the last thing was to create a calculated field, and this one's very simple. So I'll type year in for the name, and I'll put 2018 as a string value, wrapping it in quotes. And note, until you finish the formula, or if there's an error in the formula, it will tell you, same as Tableau. And so I close the quotes, hit save, and now it's added year as another field within this output of that step. So now I'll take this and rename, again, just double clicking, call it rename fields. It's the primary function of that step. And now I want to join it to the other data, so I just drag and drop this over here and drop it on that union. And you saw that the 2018 data then jumped up to the top. What happened here, now you can see this measures field way to the left with all the nulls in here. If I select 2018, you can see that they're actually measure names. So because this was misspelled, it added a new column when I dropped it in here. Measures for all of the old data elements that were in here are populated appropriately in this column. So in order to fix that, I just come back here, and I can either double click here, or I can double click on the rename field, and I take that, I should go to the right one, since that was spelled correctly. So let's double click here, take out the second A, and then when I go back into the union, you see that everything lines up very nicely now. This table names is a field that's automatically inserted by Tableau Prep, lets you know what the source of the data is. So if you're trying to troubleshoot, this is a wonderful tool to have. So I love that aspect of it. The next step, we're converting. So we went from columns to rows. Now I want to get the star scores in columns with one single row for each measure for each year. So what I'm doing is I'm calculating, I'm looking to see if the star level, just way over here to the right, is 1, 2, 3, 4, or 5 stars. This 4-star threshold is from 2015 data. CMS went through some changes. That's not useful anymore, so I just right-click on here and say exclude. So I've changed that on the fly, and it automatically updates for all the data. And so now, just to share with you the calculation, this is a very simple calculation. Look to see if star level is equal to 1 star, and if it is, I put the raw score. Otherwise, I put a null in that field, so that's why it looks the way that it does. And I repeat that same thing for the 2-star, 3-star, all the way up through 5-star. And then I remove the field, so let me come back. and as you go through the steps, you can see what the data looked like after each step, which is another fantastic aspect of the tool. So table names was in there until I came to this step and I removed it. I removed it because at this point I'm no longer using those table names to troubleshoot, and it's not adding any value, so I just wanted it out of the way. And as I do other manipulations of the data, other table name fields will be added as appropriate. And then this is the filter that I just did to take out that star level from 2015. Now here the data splits into two different paths. I'm going to start with the top one because it's a short one. And here what I'm doing is I'm taking the measure ID. You'll note that there was CO1, colon, and breast cancer screening. And splitting that into two components. One's going to be the measure number, the other is going to be the measure name. Now, right now, it's set up for calendar year 2017. I just added 2018. For our purposes, the most current star year is the most appropriate one to include in our model. So I'll come in here and filter instead of for 2017, change this to 2018, hit save. And now it's flowed through. We've got all the cut points and everything. If I select here on the last step, this is what the final data looks like. I do a group by. I'm sorry, I use the calculated field here to split out the CO1 from the breast cancer screening, and then I remove the fields that aren't pertinent. In this next step, I do a group by to get back down to one row per measure. So if I select CO1, you can see breast cancer screening only has one line, whereas it had 5 lines, one for each of the star levels in the previous step. So we'll bring this back in, joining based on the measure name to get the measure number across all years lined up. CMS does keep the measure name the same from year to year. However, the measure number does change from year to year because certain measures fall off the STARS reporting and new ones are added. So going inside here, I rolled up the data. You'll remember I had one star score, and then there were 4 lines of nulls, and then I had a null and 2-star score. So all of this has been rolled up. I'm doing a group by year in measure name, and then I'm taking the maximum value of the 1-star score, 2-star score, etc., to get rid of the nulls and have 1 row per measure. From here, I go in to deal with some problem measures. So CMS, over time, does change the way the cut points are displayed in their exhibits. So looking at this particular measure, which is a beneficiary access and performance problems, back in 2016, we had the less than 40, greater than or equal to 40, to less than 60, and so on. Starting in 2017, they changed it, so it's just less than or equal to 20, and then 40, 60, 80, 100. So I had to do some special manipulation to get these all to line up. So you can see that the output from here, I have 5 stars is 100, 4 stars 80, 60, then 40, and I drop off the one star because anything less than 2 stars is 1 star automatically. So I don't use that for any of my calculations. Another measure that posed a problem is the rating of the healthcare quality. In 2015, CMS decided that they're going to put an asterisk here because you can see that the 2-star cut point ends at 85%, and the 4-star cut point starts at 85%. So there's really no range here for the 3-star cut point. For my purposes, I decided to take the 85 from here and put it in for the 3-star. So let's go into some of the calculation here just so you can see this a little bit more closely. So first thing I do is determine the direction of the measure. As I mentioned when we're looking at the spreadsheet, sometimes higher is better, other times lower is better. And so this looks at the 1-star cut point and compares it to the 5-star cut point. The 5-star cut point's higher. It says higher is better, otherwise lower is better. So that's pretty straightforward. I replicated this from other steps. So I didn't build this for this particular measure, but it still works effectively. So I just left it in here. And then for this particular measure, I look at the, because this is all higher is better, I look at the 5-star cut point, and let me move this over a little bit. So looking at the raw information that comes in for 2017, it's greater than or equal to 88. I also want to point out on this measure for 2015, it was greater than or equal to 88%. 2018, it's greater than or equal to 87, and 2016 was also a percentage. So CMS has changed the format of the numbers in this particular cut point, which I address later, and not in this particular step, but just wanted to point that out in case you're wondering if I'd noticed. So looking at this, and I take the last two characters off, or I look at the length of the string and take all but two characters from the right-hand side to get the numeric value. And so you can see the 88, 0.88, 87, 0.88, because I create a float numeric value out of this process. For the 4-star, it's a little more complicated. I do use the direction, so I know which part of the string to go after. So with the direction, if higher is better, then I start on the left-hand side, but I'm going from the 3rd character, which would be right here, the 86, the 8 and the 86. And I'm going through to just before the 2 in that string. And the second part of this, if it had been lower is better, then I'm starting after the 4 places after the beginning of 2, which would put me right here at the beginning of 88, but that's not the case here, and would go through the end of the string. So that's that calculation. And this is what deep as I'm going to go into the calculations for the most part here. Then once I have all these special measures handled, I dive into the remainder of the measures, and they all fit the same format, and they all use the same formulas that we just looked at. And at the end of this, and I want you just to note that 2018, since I've added it, is flowing all the way through these data. It wasn't there before. So then I bring all of these data together using a union within Tableau. And as I mentioned, with some of these functions, Tableau automatically puts the table names in here. So you can see that I have just a little bit that's coming from this table, a little bit from this table, and a little bit from, and most of the measures coming from this table. So this would be a small one, this would be the large one, and this would be the small one. So all those data elements flow through into the union. On the next step, I adjust the caps measures as I just talked about. So there are certain measures that are caps. So the one measure we're looking at was one example of about six different measures. And so if the measure is measure values between 1 and 100, and it's one of these measure names, and so you can see there are actually 7, then I divide that result by 100 to get it down to a percentage. Otherwise, I just leave it as a percentage. So that's that step in a nutshell. I repeat that for all of the different star levels. And then I do some cleanup. So when I get to the end of this, I'm left with this relatively clean data step that's useful for our purposes. CMS also splits the Part D cut points into PDP, which is a Part D plan. Let me click off here. And then MAPD, which is a Medicare Advantage Part D. So there are 2 different types of plans. The PDP only offers Part D coverage, so medication coverage. MAPD offers the clinical coverage as well as medication coverage. So in order to align these data to our process, I create 2 equal sets of data, one with PDP as the calculated field. So you can see right here I have PDP, and then the other one has MAPD here. And it's just this easy to check to see what's going on within Tableau Prep. Then I've joined these 2 tables together, I stack them up, and you can see here that have MAPD and PDP, they're equal in number of records, 131 rows each. And so I brought those all together. And then on this next step, I join, again, based on measure name, to get all of the measures that persist in the new report year labeled, and also in previous. So any measure that's been carried along over time, but definitely all the ones in the new year are numbered as identified in the new system. So I join, again, based on measure name. I bring in all of the detail that we've already discussed. And then I put the measure number on here. In the next step, I just clean up the data. And so you can see that I'm left with all of the key elements that I care about. I've got the different cut points, which are a lot easier to look at than those less than, greater than, equal to values. I've got the direction of the measure, which is part of the information conveyed by those string values. So we've got higher is better, lower is better. And you can see most measures are higher is better, which is easy to align with people's thinking. The lower is better, throw people off. And then we have the org type, the year that the cut point was applicable, the fact that this is part C rather than part D, and the current measure ID. So that is then what my output looks like, this little bit right here. That is everything that I wanted to convey. Just wanted to let you know that from my experience as somebody who's worked with data for almost 2 decades, being introduced to Tableau Prep earlier this year was a surprise, a very welcome surprise. And I love what this tool does, and I've identified a number of other areas where I can use this tool to take what was a very difficult and challenging aspect of aligning my data for reporting and made it much simpler because of the flexibility of this tool. It's fantastic. Thank you, everyone.
Thanks,
thank you.
Thanks,
Sorry.
Donovan. That was really good, and really great to see Tableau Prep get some love and attention for once, and it not all be about Tableau Desktop. So thanks for taking us into quite a unique territory for the healthcare user group, and really appreciate your time. Sorry, Nicole, I interrupted you.
Well, thank you.
Okay, cool. Well, I will now try and share my screen. So I will try and just make myself embarrassed to see if I can get the IT working. So that brings us on to the Q&A. So I think there was one question for Donovan in that last session. So bear with us 2 seconds. So Donovan, someone attending asked, can Tableau Prep output results directly to a SQL Server database? Do you know the answer to that? I
don't know the answer to that myself. I know that it can be output in a number of formats. I'm not sure if outputting it directly to a SQL Server database is one of the options, though.
Okay, thanks for your honesty. I'd suggest to that person you might want to reach out to the Tableau community or post it onto the forums page for Tableau Prep, and I'd imagine to get a response really, really quickly. So that'd be a good place to put that. So I think that answered all of the questions, and the questions that have been asked so far. Lindsay answered a couple via the Q&A window, so thank you for doing that. So unless anyone has any final questions that they wanted to ask, then I think that's us calling it a day. Just to remind everyone that the recording will be shown, will be put onto our Tableau community page. So that will be up hopefully in the next week or so. And there will be a healthcare meetup at TC18 in New Orleans. And if anyone follows Mark Bradbourne on Twitter, you can get a daily countdown with some rather dodgy GIFs. So that's always something to entertain you for a day. But that's currently an arrangement.
All right, I think we just lost Simon. So we're going to wrap this up. Thank you, everyone, for attending. I really appreciate it. And you'll hear from us soon. Thanks.
Thanks, Nicole.